Hello, everybody, and welcome. We have over 600 people signed up for today's interactive case study. So thank you for signing up and joining us today. We do have an exciting one that is off of the request of some of you out there, some of the requests to look at some posture-related stenosis, and in particular, we're going to look at a dance teacher that is retired that is dealing with chronic low back pain and stenosis. So again, welcome everybody to the Pilates Hour, and excited to be with you today. Thank you for joining us from all around the world. We're going to talk about stenosis today. So stenosis is a very common pathology. It is often overdiagnosed. One of the things I want to talk a little bit about stenosis before we start with this case is that it is a normal degenerative change that we have in our bodies as we age. So all stenosis means is that there is a narrowing taking place of a foramen or of a lumen, some kind of space. You could think of having a hose, and if that hose, that watering hose or garden hose had stenosis, it would mean that there is a narrowing of that hose. So it's going to increase pressure. If there was a nerve in that space, like the foramen in our spine, which I'll show you an X-ray of in a little bit, or MRI, that would be a narrowing around that space. And it's not always bone. So for example, there could be scar tissue, there could be a tumor, there could be inflammation, there could be a narrowing of space. All of those can cause stenosis. Stenosis in and of itself is not symptomatic unless it is causing more inflammation and pressure. The stenosis we're going to be talking about today is a lumbar spine stenosis, and that is going to be when we look at the vertebra and we see the spine, the foramen, the side where the nerve roots exit that spine, that is where we're going to see our narrowing, and that narrowing is putting pressure on the nerve root. And it's important to understand that the nerve root is surrounded by the epineurium, which is a continuation of the dura. That's the protective sheath that protects the nerve. So it's not always that we're putting pressure on the nerve, but we're putting pressure on the protective sheath around the nerve. And that protective sheath is sensory integrated, which means that if we put pressure on it as a protective mechanism, we might have pain or pins and needles or burning down that respective nerve distribution or that dermatome. That does not necessarily mean that we are having neurological problems. So I want to be real clear with this. A neurological problem, for example, would be so much pressure on the actual nerve that you lose sensation, or you have a loss of proprioception, or you have a loss of power in motor or balance. That is different than having pain and having pins and needles or burning sensation. The pain, pins and needles, and burning sensation are a warning sign saying, hey, something is narrowing, and there could be an inflammation around the dura or the epineurium that is causing that pain. So I always like to clarify that. There was a great study done. We've talked about this when we go into chronic pain, where they looked at 1,000 or so individuals that had never had low back pain between the age of 25 and 75. And what they found was that progressively with our age, that there was a high incidence of stenosis of the lumbar spine. Again, these were all individuals who had never had back pain. So what we refer to that as is a false positive. So if you went into the doctor, you happen to have an acute episode of low back pain, and you also happen to be one of those people that had had stenosis for years but never had symptoms, it is likely that the doctor might diagnose us as having a stenosis that is causing the pain, even though that stenosis maybe has been there for 30 years and is not the culprit. Another important thing is that once we inflame a nerve root, the inflammation actually takes up space in that foramen that could be causing the symptoms to worsen. And that's why a lot of times the first approach to stenosis medically is to get an epidural or to go on steroids to try to decrease the swelling of that nerve root. Long-term and sometimes more aggressive treatments are going in and surgically doing what we call a roto-rooter, where they clean out the foramina and possibly do a fusion or a spacer or a lateral approach where they prevent you from going into extension and they increase the space around the nerve root. So that's sort of my little quick down and dirty lecture on stenosis. If you have more questions on it, please feel free to put those questions into our Q&A. I see a couple coming up now. Rosanna de Guzman said, what is the treatment to follow when you get those warning pins and needles, burn, and numbness? And that is what we're going to be talking about today. So that's a great precursor, Rosanna, and I will answer those questions. Alice Joy Crusat said, can you give a reference to that study of asymptomatic spinal stenosis, please? I will put it into the after production. It's in one of my other presentations for chronic pain. And we do have a couple studies there, especially out of Japan, that have shown the incidence of false positives. All right, let's go to the first slide. Let's introduce you to the case today. So Barbara's a 72-year-old female. Of course, I changed the name and some of the details to protect privacy. Relatively good shape. Her primary complaint is severe shocking pain in the lumbar spine, buttocks, and on occasion down the back of the right leg. Her symptoms are worse when she is performing a sit to stand. So she's been sitting for half an hour and she goes to stand up. She gets that sharp, shocking pain in her back, especially when sitting in lumbar flexion postures on the couch, propped up in bed, airplanes, and even on the toilet. Severe pain can last for a minute, but inability to stand erect can last for minutes, often resulting in sitting back down due to fatigue of trying to stand up with pain. Symptoms have been worsening over the past few years, and she is afraid that she will need surgery. So she has gone to the surgeon, and the surgeon from the MRI has scared her a little bit. And whether that's right or not, there is a fear here of needing to have surgery. And the surgery would be an aggressive surgery. It would be a 2 to 3 level fusion. They would be cleaning things out. They would be doing bone grafts, and they would be doing a combination of rods and screws to be able to fuse L4, 5, and S1 in this particular case. Barbara's recreational activities, she's a retired ballet dancer. She's taught ballet for more than 30 years after retiring as a professional dancer. She has 2 grandchildren that she wants to enjoy and feels she is limited due to her stenosis or the symptoms that she's feeling from stenosis. She currently tries to walk an average of 2 to 3 miles per day or water exercises in her pool on days that are warm enough or when she cannot walk due to pain. I see a couple other things coming up here while we switch to the next slide. Christina Lazarescu had asked the question, how efficient is cortisone for stenosis? And quite often, cortisone and steroids are very effective very quickly and can prolong the need for something like a surgery or at least get rid of the pain so that we can work on other strategies to be able to work on that. Great question. In the patient interview, I always ask, what do you believe you're not able to do that you believe you should be able to do? And for her, it's primarily stand up and walk, get up and down from the floor and go up and down stairs without pain. So, she's an active person. She wants to be outside. She wants to be able to go shopping. She loves shopping. She has grandkids. She wants to be able to get up and down off the ground. She's always been able to be on the ground. And just because she's 72, she doesn't feel or has never perceived that she would be in this predicament of having to be limited in her ability to stand. When asked, what do you believe prevents you from participating in these activities? She just flat out said, sharp pain in my back and buttocks. So the pain is her primary belief of what's stopping her. It might not be that she's weak or can't do it. It's just flat out the pain inhibits her from performing her daily activities. So when we put this into perspective of what we refer to as the ICF model, the International Classification of Function model, This comes from the World Health Organization. What we're looking at here is somebody who has structurally, and we'll see this in a minute, structurally has some bony deformities of the stenosis in her spine. From an activity standpoint, standing up from a chair and walking are limited. And from a participation, basically ties into her belief she's not able to participate at the level in her recreation and her daily activities that she believes she should be able to participate. Let's go to the next slide. While we're doing that, Jocelyn Toomey asks, would stenosis cause foot numbness and loss of dorsiflexion or change in foot function? If it's at the L5S1, absolutely. An L4L5 could certainly cause that effect, right? And more severe cases of stenosis, we quite often see foot drop. We see the inability to stand up. It's accompanied with severe stenosis and kyphosis in the back, as well as a loss of hip flexion or hip extension and a loss of ankle dorsiflexion. So those are all things that we could see in a more advanced case. Now, I forgot to mention that Barbara has been dealing with this now probably for about a year, progressively getting worse. So we're not at that point where we want to do surgery. We want to see if there's anything we can do to help her out. So before we start the assessment, based on the subjective information to this point, what would you hypothesize Barbara needs the most right now, right? Based off of what she said and based off of how she presented in her subjective information. So let's take a minute, go ahead and answer those questions. I like to get as much. And by the way, today, I didn't put multiple choice questions in today. I really wanted to get your participation. So I hope that you'll get into Mentimeter, take the time to do so. And the code is on the chat. It's also on the top of every screen. But get into Mentimeter, whether it's on your computer or your phone or your tablet, and participate as much as possible. And there are going to be a lot of open-ended questions regarding Barbara's situation. I think that's important for each of us to be able to contribute in a way. There is no wrong answer in this forum. One of the things I believe firmly in is that by creating the demand to try to think about what somebody needs or what's the right thing, only opens up possible channels of creativity and finding solutions that we can do together. So let's get about 10, 20 more of these possible hypotheses. And remember, a hypothesis is before we have any objective information. All we know right now is what Barbara has told us and what she has presented to us in her interview. So let's go ahead and start showing these because it'll take us a minute to read through them. Great. So I see some really nice ones up here already. Regain her confidence, stop being in pain while doing her daily activities. I think that's important because remember, her primary limiting factor is her pain. So somehow we have to teach her how to move without that sharp initial pain that does go away within a minute or two. So if there's a way that we can find movement without pain, is going to be a major, major, major solution for her right now. Once she's up, she's walking 1 to 2 miles a day. Once she gets into a vertical posture, it's getting into the vertical posture that's been hard for her. I see some modalities coming up, like some rest and some heat. A lot of times heat is very nice with arthritic changes, trying to get the muscles to relax that are spasming. But for the most part, I see here nice things like really teaching her how to move and especially sit to stand with proper form without the sharp pain. I also see some of the strengthening things here on this one, which I will come back to this one over and over again today, in the combination of mobility and power and proper alignment. And I want you to take into consideration Barbara's old school ballet, right? She was classically trained, Russian style. And when we take a look at her posture, a lot of these things are going to make a lot of sense. Great work. Let's move on to our next question. And keep answering at this level. That was 45 questions, so that's awesome. So here we have her results of her MRI and bone density test. and her MRI showed that she had significant degenerative joint disease. Now, that shouldn't be surprising for a 72-year-old ballet dancer, right? A lot of movement, a lot of load over the years, 72 years old. Remember, I talked about the false positive diagnoses that just normal, people in their 50s, 60% of them have DJD in their spine. As we get older, it's up into 80 and 90%. So it is a normal progression. One of the things that was disconcerting about Barbara's MRI was the severe facet arthritis, right? So if you think about the anatomy of the facet or the spine, and I'll show it to you in a second in the slide, that if the facets become bulky and bony and inflamed, they can push into that nerve root foramen. And that's exactly what she is dealing with right now. It's not all the way closed, but it's significant. And she also has had a significant loss of disc height in the lumbar spine, L5 and S1. So what that means is that if this is L5 and this is S1, and it's coming down, right, it's going to be putting pressure, more pressure on that nerve root coming out merely because of the loss of height. So that's really important to remember. Barbara also had her bone density test, and she has a moderate to severe osteoporosis in the lumbar and lower thoracic vertebral bodies. And her femoral neck showed osteopenia, so earlier stages of bone density. Also not uncommon with slender women in their 70s, very common to have bone density issues. So this also creates a little bit of a dichotomy for us. If you think of what is the limitation or contraindication for bone density issues in the lumbar spine, the answer is flexion with compression or flexion with force, right? And if you think of stenosis, the contraindication is extension of the lumbar spine. So what it's telling us is she doesn't have a lot of movement options theoretically in the lumbar spine. So I want to put that out there, is that mobility in the lumbar spine might not be our first approach. So I want you to think of where else might we increase her mobility to be able to stand and move if we do not really have access because of the stenosis and the osteoporosis in the lumbar spine. So keep that in mind. That will help us out. Let's go to the next question. Oh, actually, here's the slide, right? So what I want you to see is that if you look at where the arrow is, this is part of the facet, and the facet is putting pressure into the lumbar canal, right? And the white thing coming down, that is the spinal canal, and the darkness inside that canal is the cauda equina, which is the sort of the end. It's called like the horse's tail of the spinal cord that is coming down. So even though there's a lot of pressure on this area, you see the herniated disc and the degenerated disc from the front, and you see the stenosis coming from the back. So that's putting pressure on the nerve and on the nerve root, okay? So that gives you an idea of what stenosis looks like in there. And as bad as this looks, right now she's only having pain and warning signs. She's not having weakness, loss of reflex, loss of proprioception. So in my mind, surgery is only when you have a neurological loss or that you cannot function because you can't stand up, okay? So until then, we're looking for other ways, because the surgery in and of itself will create other limitations and other problems. All right, so let's go to the next slide. So objective measures, right? So she comes in and we're looking at her posture. She has a sway back, a flat lumbar spine, pelvis is posteriorly tilted. I want you just to imagine that typical ballet dancer, of old school ballet. We've been working really hard over the last 30 years to try to re-educate. Eric Franklin's done some amazing work on trying to teach the bone rhythms for dancers so that they're not always thinking that the external rotation comes from the pelvis, that they have to differentiate the movement. We talked about like a jar opening. If I want the femur to spiral out, I have to think of the pelvis spiraling in to create that oppositional movement, right? So she's a very good case of this. Literally, there is no butt muscle. So if you were to look at her and to palpate glutes, very, very little glute muscle. Her weight, she's 115 pounds, very slight frame. She does have a graceful carriage of her upper body, and she stands in external rotation, as you can imagine. If you've been working with classically trained ballet dancers, especially dancers from the 50s and 60s, you're going to see these type of postures. When we looked at the active range of motion, lumbar spine, less than 50% in all planes, right? Pain on the return from flexion to vertical posture. That's her worst movement, is flexion and then standing up from flexion, or being seated and standing up from being seated. This quite often is a fluid dynamic problem as well. So if there's inflammation or the facet capsule pushes in and around and is spreading out a little bit because of the spine being open, being flexed, when you go to stand up quickly, you might have to wait a while for that fluid dynamic to change that allows her to stand up. And she is able to stand up and to go walking gracefully. It just can't happen right away. And if she stands up too fast or urgent, like the doorbell rings and she jumps up to get her the phone, that's when she gets that huge electrical zinger that takes her out. Moving on, thoracic spine, 75% loss in extension, right? 50% loss in flexion, rotation, and side bending. So she's already starting to show some kyphotic changes in the thoracic spine, and she already has quite a bit of limitation there, but there's no real pathology in this area. So this, I want you to think of that thoracic spine is a key area for us to draw attention to. And if you've listened to me in the past, and most of you have, we start looking at things like thoracic mobility, hip mobility, and ankle mobility to try to decrease the stress of the lumbar spine, which is exactly what we're going to want to do with Barbara. Question coming up from Teresa Maldonado. She says, how do I determine 50% loss of spine flexion if flexion is contraindicated with osteoporosis? She's usually in flexion. And when I talk about flexion, typically we're looking at flexion with compression that is contraindicated. So that would be like having her do, a roll up or hundreds or some kind of forceful exercise. Her reality is that she often is sitting or standing in lumbar flexion. But when we just look at her moving, her flexion is really coming from the upper back a lot more than it is coming from the lumbar. And her most difficulty is returning from flexion into posture. So that's just her normal movement, right? Hips showed moderate loss of hip extension, 50% loss of internal rotation, 0 degrees, and external rotation was about 60 degrees. So she's sort of resting, turned out with her hips. The fact that she doesn't have neutral or internal rotation of the hips would tell me that her abductors, rotators, and glutes are not really performing or acting in her daily activities, right? And the last one is in her ankles, decreased dorsiflexion bilaterally, so not a lot of dorsiflexion, hence she's always walking in turnout. Plantar flexion is more than full range. She still has a beautiful point. I don't think she'll ever lose that. And very proud of her point, but we do have a problem with dorsiflexion. So a couple things to be thinking of at this stage of the game with these objective measures. Posturally, she's in a posterior tilt and flat lumbar spine, okay? She has pain with the return of flexion to extension in her lumbar spine. She has relatively poor mobility in her thoracic spine, hip extension, and hip internal rotation. She has very little muscle activity going on in her glutes or her external rotators of the hip. It is more of a passive position that her pelvis and her legs are in. And when she walks with her feet turned out, primarily relying on things like the hamstrings to propel her by pulling her forward, or by using gravity to sort of fall forward using her assistive device. We also know at the ankles, not a lot of dorsiflexion. Again, that's pretty habitual. which also puts additional stress into lumbar flexion when standing. Let's go to the next slide. All right, so here's your chance. You know the functional tests that we often talk about: squats, lunges, seated rotation, flexion, breathing, all of the roll up, extension, side bending, abdominal strength. What functional tests do you think, Barbara, that we should do with Barbara to further assess our hypothesis of what we're going to do with her? So take a couple moments to do that. If you have questions, you can keep the questions streaming. While you're doing that, I'm going to come back and answer Rosanna Guzman's question in a little more detail. So the question is, what treatment to follow when you get those warning pins? So this should start helping us think of where we're going with this. But if I can get hip extension and thoracic extension, I can decrease the stress of her trying to stand up straight from her lumbar spine. So we might have to accept the fact that she stays in a flat lumbar spine, but need to get a little more hip extension and thoracic extension. If we can do that and keep the perturbing forces on that nerve root reduced to a minimum, we can often reduce those symptoms that she feels of the pins and needles or the burning related to more the epineurium being inflamed and affected by the compromised space, right? So it might be something that, you know, she has to go on a treatment of steroids for a little while we are increasing the thoracic mobility and hip extension. She might need to have some physical therapy and some myofascial release to release some of the guarding and structures that are restricted in her hips. And we also need to look at some strategy. So as you guys are answering this question, what functional test, we'll let a couple more get up there to 20 or so, and then we'll go live with it. I want you thinking everything about function. What is it that she wants to do from her subjective information? And what do we know now from her objective information as far as what functionally do we want to know her strategy or her abilities or her inabilities? Let's go ahead and show it, Melissa. Now we're at 20. So we have standing rotation, compare the two sides, squats, side lying, adduction. I'm assuming that's what you mean, adduction and abduction. Good. Squat in parallel, goalpost against the wall. Good. Book openings. I see a lot of people wanting to see the squat test, which I agree with you. Sit to stand, postural exam, femoral circumduction, goalpost. Breathing is really important for her because we know we need some thoracic mobility. I see some Z sitting. I might pull back on Z sitting only because her hips are pretty strong. I mean, she has osteopenia for a 72-year-old ballet dancer. She probably could do a Z sit test. Standing balance, biomechanical range of motion, looking at the biomechanics. And biomechanics in particular, the one question I have is, does she have hip mobility? You know, we think of dancers naturally having it, but I think a lot of her mobility probably came from her back and the fact that she was naturally retroverted into external rotation. So she had a natural body for that. But does she really have hip range of motion? Or if she brings her knees to chest, is that all coming from her lumbar spine? By the way, knee to chest feels good to her because it's taking the pressure off of the foramina. Looks great, guys. Let's go on to the next one. This is good stuff. Let's see what I did. So I looked at her squat, and when she went into her squat, we had a posterior tilt, right? So immediately butt dropped under. There did not seem to be much flexion happening at all in the hips. It primarily was in the knees, going into a slight valgus position and collapsing into a little bit of pronation into the foot and into her bunions, right? So she was able to go into the half squat. She was already standing pretty well by the time she came in that day of testing, but that was her strategy. So I want you thinking, if her strategy immediately was to stay in that posterior tilt going down, right? This breaks all of Eric Franklin's rules, if you've ever done any of Eric's work, of not allowing that femur to spin inside of the acetabulum of the pelvis. For her, they just stayed together and everything looked like it was trying to rotate out. And that put a tremendous stress on the lumbar spine and on the knees. Looked at marriage proposals. So that's like a lunge, one leg forward, one leg back. Unable to perform the test without assistance. So she did not have the strength with the legs separated to be able to go down. And that was interesting to me because I felt like one of the things we want to be able to do is to use a marriage proposal strategy for her to be able to get down and up off the ground. She did not have the power or the strategy to be able to go down the ground. It was not related to pain. So I think that's another important little note to make on the side, right? Balance and the single leg, single heel lift, the releve. She actually was able to balance 15 seconds in each leg. Releve, she had the strength to do 5 to 10 releves on each side, single leg. And again, probably something that's so deeply ingrained in her strategy that she was able to do that. She did not have, in other words, loss of motor in her lower extremity. If she had had, true nerve encroachment and nerve damage, she would not be able to do the heel raises if it was the L5S1. So that just was good news to know that she's not showing hard neuroscience right now. She's showing what we call soft neuroscience. I did the sitting on the bench with the side bending and rotation. And again, that's sort of how I came up with her 50% limitation in the thoracic spine. We already talked about that, but that's how I measured it. I also looked at her ability to lay prone and to do prone hip extension. I put a pillow underneath her abdomen. Sometimes you can do this over a small arc. You could do it over the barrel where they just lay prone and look and see if they have any ability at all to move the hip or the femur into extension. Even with the lumbar in slight flexion, she was uneven. She was unable to extend her hip beyond neutral. So what that tells me is that every time she extends her leg, like just toeing off and walking, she's actually creating a little shear force in her lumbar spine. So the fact that her hips are guarding, maybe because of the pain or maybe because of old history, I assume that she had hip extension somewhere in her career. But now every time that hip goes into extension, it's pulling the lumbar spine forward. It's creating a little bit of shear force. And for that reason, her gait is a little bit more of a shuffle gait rather than doing a full brisk gait with toe off, right? She's not really getting into toe off in her gait because of that limitation of hip extension. So again, looking at the functional assessment, we see strategy issues with the posterior tilt. I don't believe that she has lost the range of motion to flex her hip. I believe her strategy doesn't let her flex her hip. So keep that in mind. Marriage proposal would demand that her glutes and her quads would work to be able to go down and up in the lunge. And she wasn't able to do that without having a stick to hold on to, not for balance, but for power. She didn't have the power. When we looked at her releve, she had the power of ankle plantar flexion. Again, she's done it her whole life. It's probably as efficient of a movement pattern as they get. And she did have good balance. She was able to balance for 15 seconds on each leg. Again, probably coming from years of demonstrating dance and standing on one leg, showing, tendus and passe développés and all of the dance moves that you would teach at bar that a dance teacher would do year after year after year. And again, she's only been retired from teaching for a couple of years. It's not like she retired 20 years ago. The sitting side bend and rotation, we mentioned, thinking of this might be an area that we can get some more mobility without consequences. So we're thinking I can get some more hip mobility. That's a strategy thing. We can probably get some more thoracic mobility that might be more structural. So breathing, some Pilates exercises that would address that as we're sort of going into the next stage of this case. And then hip extension. This might require at this stage of the game, just throwing it out there, that you'd be thinking of, how do I work in a community with Barbara? I would send her to get some myofascial release. So I would want to see her getting some nice release across the front of the hip, the psoas, the iliacus, the tensor fasciae latae, my coffee muscle. I always call it the tensor fasciae latae, and being able to get her so that she can stand with ease. Now, before we move on, there's a couple questions here. It says, I thought the steroid increased the deterioration of the bones. That was from Michaela Windsor. Steroids actually are always, our body makes steroids. So it's just a replication of the corticosteroid. When we have too much steroid, like when you have it more than once every 6 months, it is a lipid-based hormone, right? So that means it's oil-based, it's not water-based. And so it lasts a long time. And if you have too much steroid in your body from the outside, so meaning whether you're taking it orally or they're injections, they can have negative effects long-term on many aspects of our body, even to the point that we have something called Cushing's syndrome, where we now have a connective tissue problem because there's too much steroid. We would see this in the olden days with people that had rheumatoid arthritis or other types of chronic inflammatory diseases, systemic diseases, lupus, and some of these things where you would take so many steroids that would cause these problems. We also saw it in athletes. If you did injections into ligaments and tendons too often, especially in the dance world, you'd see Achilles tendon injections, and within a year or two, they would blow out their Achilles tendon or their patella tendon because it weakens the tendon. So you're right on that. Marriage proposal is, as I mentioned, it's a lunge. So what I do is you just sagittally, you take a step forward about 36 inches, 1 foot's forward, 1 foot's in on the ball of the foot in the back, and you drop straight down as if you were going down on one knee. That's why it's called marriage proposal. Will you marry me? And then come back up. And so it's one of the basic exams that we use in the Polestar assessment tool, or previously known as the FMOM. Okay. Genevieve asked a question. I think I answered her question. What are the lumbar spine precautions used to test hip extension? So great question. Remember I said I put something underneath her abdominal wall. So I tried to block her from the lumbar spine going into extension and seeing if she was even able to lift the leg. And she couldn't engage the glute. She couldn't get the leg to come off the table at all in that blocked position. So that was my precaution. So it just tells me there really is no hip extension activity going on. And she also doesn't have the range of motion from the front to be able to lift that leg. So we've got our work cut out for us. We have to do like release across the front of the hip and start re-educating active hip extension and to get the glutes to start doing some work, especially getting the pelvis to maintain a little bit more of a dynamic relationship with the femoral head, meaning that when she squats, there literally is motion inside the hip joint and not just going into the back and into the knee. Let's go to the next slide because we got lots to cover today, and these are great questions. Appreciate them. What do you believe could help Barbara be able to stand up and walk without so much pain? So we've given you a lot of ideas. Now's your chance to sort of fill these buckets. What do you think's going on there? Now, while you fill that in, I have another question that's come in from Laura Cobrell. It says, how about precautions if there's scoliosis lower thoracic on test? Funny you bring that up, Laura. This particular patient doesn't have functional scoliosis or lumbar thoracic scoliosis. But I immediately thought of another patient that I have that has almost identical, not a dancer, but she's experiencing collapse in her lumbar spine and leading to a significant increase in her thoracolumbar scoliosis, which leads me to tell you, there's a great course coming out of Polestar real soon. It's the new revised course by Lisa Stoltz and Hagit, both physical therapists that have worked really hard of making a virtual course that also is companioned with an on-site course for spine deformities, including scoliosis and other spine deformities. So you want to keep that in mind. I'll make sure that Melissa sends you out that information. That should be coming in late summer, if not September. But the precautions for scoliosis lower thoracic is the same thing. When I was doing hip extension, I'm blocking the spine for that test. if I'm looking at thoracic mobility and they're sitting up tall, there's nothing wrong with looking at their ability to move into space on their own. I wouldn't manipulate them into those spaces as a physical therapist, but I would just look and see what is their reach when they reach for a door, when they go to brush their hair or put a coat on or put their pants on, if they got to wipe their bottom. These are all things that facilitate the need, rotation, and mobility in the thoracic spine. So if she doesn't have that mobility, then we have a problem, because that means all the force is going to move to other places like the shoulder or the lumbar spine or the knees or somewhere else. Let's open it up and see what people are saying. What do you believe could help Barbara be able to stand up and walk without so much pain? All right, so I see a couple here. Hip flexor release, glute strengthening, hip hinging strategy, great. Hip and ankle mobility, glutes and core strengthening, awesome. Teaching awareness of neutral spine and pelvis, yeah. Disassociation, right? I think if we could get that disassociation into her and really teach that idea of the jar opening, she's a professional mover. It's not like it's going to be impossible, but that's something we have to really educate. And immediately she's going to feel weakness because she's been into that sway back posture and she's been hanging on the ligaments of her hips rather than the muscles of the hip. And I have a cute little story for myself. After I had the hip replacement on my right hip 2 years ago, I started doing my exercises and I felt this incredible pain in my right buttocks. And my friend, that's physical therapist that was working with me and sort of forced me to go through the exercises, I asked him, I go, like, everything's great. Like, I have no hip pain, but I got this pain in my right buttocks when I do the squatting exercise. And he's like, it's because for 30 years you've had impingement anteriorly, and whenever you've gone into a squat, you have supported yourself with the restrictions in the front of the hip, and you haven't needed to use any of the glutes or the rotators or the piriformis in the buttocks. And so what I realized very quickly is I had to wake up those muscles. I had to re-engage that, right? So that was an interesting one. All right, so I'm seeing some very good ideas here, and I think we're all really on the same page, that we have this combination of strategic mobility, structural mobility, strength, alignment, everything that sort of ties into our principles. Let's go to the next slide and the next question. I'm going to give you some more insight here. So from a movement strategy standpoint, Barbara's posture and movement strategy predispose her to excessive lumbar flexion, right? If you don't flex the hips, right, you're going to end up going into lumbar flexion. So that was with every squat or sit to stand. Her strategy was that it was going to come from the lumbar spine. She did not have any inkling of sitting down, sort of like we talk about spreading the sit bones apart as you sit down. And I believe over her lifespan, she has developed significant stenosis, wear and tear in that area, that does not allow much lumbar extension anymore. So we're going to have this battle now that she's not going to be able to get extension from the lumbar spine. We're going to have to find it from somewhere else to be able to allow her to use her hips appropriately. All right. And I'm saying that's probably going to be coming from the thoracic spine and maybe the ankles. Okay. Let's go to the next slide. There's a question here from Michaela again. Is marriage proposal the same as half nil? And yeah, it's pretty much half nil. I can show it to you. So if I'm here and I just step out, one leg back, and I'm just going to drop straight down to the floor and back up, would be what we call marriage proposal. So that could be a half nil. And sometimes we measure it with, maybe they can get halfway down and come back up. You also have to switch legs as to which leg is in front to be able to see what's going on there. All right. Is there a way to measure what is normal lumbar extension, from Lisa? Yeah, there is. And I'm thinking of you, Lisa. I'm thinking of your body, and I know your body, and I know you're going like you're eating this up because you've been in that world for so long. But yeah, the lumbar extension, when we look at a spine, like one of my favorite things to do now is to have some, matter of fact, I was doing this with my mother last night. I had her sit on the narrow neck of the oove from Daniel Vladeta in Australia. A lot of you know the oove. And I had her sitting on it like a saddle of a horse. So there's literally no pressure on the sit bones. And I had her moving, and she has pretty severe stenosis. My mom is 84 years old, and she walks bent over a little bit. And I also have some early stage stenosis that I know of already from MRI. So I get this pain, I understand it. But her sitting on the oove, I could see her pelvis, right, rocking back and forth. And what I was looking for was how far forward, how far back can she go, and where's the middle of that space? So as stenosis progresses, what you'll see is that their neutral position where they move from is going to be more and more in a posterior tilt, or more and more in a flat spine. So even though they might have some movement, you have to think of where is the neutral zone for this person, right? They're never going to be that, lumbar extension position again that you would think of, oh, this is what neutral is in the Kindle and Kindle book with stenosis. You're going to see it moving more and more and more from this position, right? From a lumbar lordosis into more of a flat spine, a little bit more flexion. Let's get going here on this slide here. I see only 3 responses. How can we help Barbara substitute her lack of mobility in her lumbar extension when sitting, squatting, and walking, right? And so a couple questions here, but let's get them out. Let's see what you guys think. And again, I hope that the redundancy of what we're talking about can make life a little easier for you as a Pilates teacher and a therapist, is that, we don't have to go in and treat the lumbar spine. What we need to do is increase areas that can decrease stress there. We don't treat the stenosis. We don't go in and break up the bone growth around the joint. We don't go in and, reduce the inflammation around the nerve. What we do is get thoracic and hip movement and ankle movement that can absorb some of these forces so that she's not always pinching the nerve root every time she moves her body, right? This is sort of the concept. How do we get into that area to be able to do that? So your answers are spot on. Thank you very much. And I see some great things like chest expansion. We can use breathing. We can use things like, depending how we prep her body, we can have her doing some thoracic extension over a spine corrector while her lumbar stays in a relative flat back position. We don't have to put her into lumbar extension to get thoracic extension in the Pilates environment. That's a really powerful tool for us. Pelvic clock in different positions. I like that idea because we can go very subtle. She still needs to have pelvic movement, right? She's still like going to the bathroom, putting on shoes, getting dressed. You can't take away lumbar and pelvic movement completely. And even the patient that I was referring to that had the combination of the scoliosis and the lumbar stenosis, they did a fusion at multiple levels right down into the sacrum. And that, even in her brace, she still has pelvic movement that's happening. So thinking of how do we have a little bit of movement and teach her what's appropriate, and also pacing. Remember, what actually caused the sharp electrical pain was when she moved too fast getting up out of a chair, right? So if her strategy was only to go into lumbar extension from lumbar flexion, that's going to always irritate her. So we also have to teach her some strategy of where her movement should come from. So if she has a little more ankle dorsiflexion, scoots forward in the chair, takes a minute, gets her thoracic extension to get the center of gravity over her legs, and she comes up gradually with increased hip extension, we can almost avoid the shear force in the lumbar stenosis. Great stuff. Yep. And I also see some good stuff here thinking ahead of time. Foot correct to work for the bunions. Yep. Because she's a pronator, and she's a pronator because she walks externally rotated. So she doesn't have that ankle dorsiflexion, and she doesn't have the ability to toe off the second and the first toe. Beautiful stuff. Let's go to the next slide. We're getting close to the end of our time, so I want to keep bringing some things in here. The second was loss of hip power, right? So regarding Barbara's posture, she does not have the proper strategy nor the strength, right, after so many years to help hip extensors, like, you know, the glutes. They were really, really weak. Rotators and adductors as well were loss efficiency, right? So that's something important for us to know. Let's go to the next slide. So here we're looking at how do we get strength in this area, right? So what principles of movement would you prioritize if Barbara now, with all this information we have, Barbara shows up, what would you want to prioritize? And while you do that, I have a question from Azita Costa, who says, how safe is it to work with her due to severe osteoporosis in her spine? Now, remember I said moderate to severe. The things that we have to be careful of, Azita, is any kind of flexion with compressive force. So for example, if you were trying to do roll-ups, that would be contraindicated. If you're trying to do 100 in a flexed spine position, that'd be contraindicated. But you could do, Sherry Betts, for example, is a great leader in our profession as it pertains to bone density and health, working with the elderly in a lot of these issues. And one of the things that she has done for years is modify the exercise so they can still do the exercise. Your primary focus is that thoracic extension, and you can still work on core strength by doing things like in quadruped or standing vertical load, or all things that can help increase core strength without having to do flexion of the spine with resistance. So I hope that answers your question there. And Lisa is warning me about using the term elderly because now elderly, I think, is 95 plus. I think that's the new term for elderly now that I'm getting close to 60. All right, let's see what you guys said. What principles of movement would you prioritize for Barbara? So I see a lot of movement integration, breathing, mobility, control, alignment. All of these principles are correct. So don't think any of them are wrong. It just helps you see how other people in our profession think at the same time as, you know, where would we go with it, right? So, you know, for me, you know, one of the first things I would do, I think, is breathing. And breathing is pretty high up there. But I would do the breathing because I really want to get into that thoracic mobility, and I want to teach her how to control the pain. So breathing is a powerful area, right? We also know that the mobility, right, getting the mobility in the hip and thoracic spine would be very important, even before we start working on some of the control. And the alignment is very important, right? So we know that she lost that alignment in her pelvis and hip. So we would be focusing on the alignment in the pelvic and hip, and then we can add load to work on control. So I like sort of the ratio that you have there. And starting with one versus the other isn't going to make or break this case. I want to be very clear with that. If one of you started with alignment and one of you started with mobility and one with breathing and one with movement integration or control, it's not going to make or break it. What you might realize is you try to get into alignment and there's not enough mobility, then you would choose mobility before alignment. If she can do alignment with cueing, then you don't need to do mobility. Now it's more about control, right, in the alignment. So the reason why, or movement integration, right? So these are all appropriate. It's sort of a trick question. Looks great. Let's go on to the next slide. So in summary, right, focus on functional activities with Barbara. She wants to participate in walking, standing, squatting, up and down off the floor. Those are the primary activities she wants to participate in. Structural limitations that we saw, real structure that we think, lumbar extension, we don't think that's reversible. Looking at the MRI, looking at her signs, looking at what provokes her pain, we feel lumbar extension, we should probably try not to go there. That's going to be a contraindicated for us, or at least a precaution. Thoracic restrictions in all planes that we can focus on, especially thoracic extension, right? A little bit of side bending rotation. And we also notice that she has prolonged loss of ankle dorsiflexion. So those are structural limitations. Strategic limitations, right? This is where we cue her and she can do it, was the hip mobility and flexion. External rotation, internal rotation, abduction, adduction. So we know that we want to be able to really restore that hip mobility in all planes. I forgot to put in there that structurally, I felt that myofascially, she has restrictions into hip extension. You notice I didn't put it into the strategy. So if I did the slide over again, I would put hip extension under structural limitation, that I think she's going to need a little bit of manual therapy and myofascial release to address that. The strategy will always be for all of these things laid on top of it. So if I was a Pilates teacher, I would look at this from the strategic limitations and do all I could do within the strategic limitations. And I would be partnering up with somebody in the community that's a myofascial release therapist, a PT that does manual therapy, a chiropractor, maybe some acupuncture or some dry needling to free up some of the fascial restrictions, to be able to complement the strategic work that we're doing in Pilates. Okay, let's go to the next one. And while you're doing that, I got Teresa Maldonado back on here, longtime friend. Just so I'm clear, you're saying sitting and standing roll down will be safe for her because it's not loaded. Remember, gravity is load. So I'm not saying that. Sitting, you're not going to stop her from sitting, and standing are fine. But doing roll downs, you're now dealing with gravity on it. So we're really trying to stay away from anything that closes the anterior space. And it is loaded because of gravity. If we can get a lot of load in the vertical space, so let me explain something anatomically. The question, and Teresa knows this. She's a well-known physical therapist in the industry. The cortical bone in the back of the vertebra is very strong. We don't have any risk with bone density typically with extension, even extension of the lumbar spine as it pertains to the osteoporosis, right? Where we have the problem is in the trabecular bone that is in the vertebral body in front, particularly at the fulcrum of like T10, 11, 12, and L1, 2, 3. Those are the areas that are most susceptible to microfractures or burst fractures. And this is the silent disease, right? So most people don't have pain with osteoporosis. It's just until they actually have a fracture or they continue to lose height or function, right? So Barbara's at an age that if we did, it just happens to be a comorbidity that she's dealing with. She's not having any signs or symptoms as a result of her osteoporosis. It's just something we need to be aware of, that we're not going to be taking her into compressive flexion activities thinking that we're going to get away from that lumbar stenosis, right? The real issue here is her stenosis, her posterior tilt, and her lumbar flexion, which we need to be careful of. Her precaution, more important than anything, because of provocation. What makes it worse is lumbar extension. Okay, so I want to be real clear with that. Lumbar extension is the provoker, right? The provocation of Barbara's symptoms. The osteoporosis is a side note, a comorbidity that we as practitioners need to take precautions to not create additional injuries to her. The last thing we want to do is create a microfracture or burst fracture in her spine by teaching her how to do strong abdominal exercises in flexion. Contraindicated, not going to happen here, right? So I hope that answers that question. I'm also in the field, and Teresa's question, I'm not a big fan of taking away all movement from people, right, that have bone density. Barbara puts her shoes on every day. She sits in a soft couch. She puts her pants on. She bathes. She does all the activities, goes to the bathroom that require lumbar and thoracic flexion, right? Is it loaded? Probably not so loaded sitting on the toilet, wiping yourself. Probably not so loaded sitting on a chair, putting on a shoe. But it could be, right? And if she holds her breath and increases pressure, she could have some other problems that are created from the Valsalva. So again, it's just teaching her the more mobility she has in her thoracic spine in other planes, the more mobility she has in her hip, the less we keep promoting lumbar flexion, the better off she's going to be in the long run. So how can Pilates practice help her now? Let's take a look at your answers. So again, I saw one that passed by me there. I barely saw it, but Addressing her habitual strategies, I think that's really important. Education, education, education. The assistive environment, we can start introducing some nice new movement into all planes. Get her to fill her butt again. Amen. Get that butt working. It's so amazing how these strategies just continue on, and we want to try to improve that strategy. So you're all right looking at this, looking at your suggestions. And I think that she would be successful in any of your hands based on what you're writing up there. I hope this has been helpful to you. I hope that, again, you're trying to see the way, at least from my eyes, how I look at some of these different pathologies as a Pilates teacher and also as a physical therapist. Nobody can do everything for everybody. So I think the key take home here is we practice within our scope, and we collaborate with other professionals that can get rid of the ego and focus on the individual and look at this and say, and maybe Barbara, after 2 weeks of Pilates, all of a sudden she's like, wow, it was hip mobility. You gave me hip mobility back as a strategy. I don't have low back pain anymore, right? That might be all she needs to be able to do the activity she wants to do, giving her good hip biomechanics, right? And it's a case-by-case basis. So right now we're just speculating, going into working with her, and we'll see how it pans out in the future. I just want to get to the point where, I think that the clearer we can make this information, the bigger picture we can look at function, the better off it's going to be for the patient and for ourselves as practitioners. A couple last minute questions. I see Elena. She says, so what are the top 2 to 3 Pilates exercises could be the best for helping any case of spinal stenosis? There isn't a top 2 or 3. I mean, think of, do we work on disassociation? Do we get her prone on a box with a tower bar sprung from below and work on some hip extension from a flex position to a neutral position to start waking the glutes up again, where her lumbar is supported with a little pillow underneath? Do we work with her on a chair, learning how to disassociate the hip in standing single leg press? Do we work with her seated on the chair, being able to do leg press, double leg press with a chair, or pull the dowel out so you have the pedals, and being able to work both legs alternating and still maintain that upright posture without provoking, right? Being able to get on the barrel and lay prone over the barrel and work on just thoracic extension without going to the lumbar extension. So I hope that, Elena, gives you some ideas of what we can do. Look, we got to close. I know we're over time. You guys were awesome. I knew there were a lot of questions, and sometimes we can't get through everything. We'll continue to provide meaningful information to you. Your feedback is always amazing, and we appreciate it. A couple of heads up. Run-T Fundamentals is open for registration. It's a asynchronous course. We've talked about that before. You can just go on and take it anytime. The mind setting course filled up right away. So we're going to be putting another one up in the next couple months. So if you were interested in the mind setting course and you missed the registration date, don't worry. We'll be putting another one up. We also have the MAT and the Reformer courses that are completely virtual. And I have heard from people telling me that they love it as a refresher, even though they've been trained, to be able to work with Shelley or with Nicole and to go through and to meet with other people and go through this work virtually has been very beneficial to them. Also, there is a transition course coming up in August. It's going to be right here on the farm in North Carolina. That's going to be with Shelley Power and with myself. So if that's something you want to do as an update, or you wanted to actually do you're not gone through the training with Polestar and you want to, that's a perfect, 7-day opportunity to be out here in the beautiful farm. Lots of meditation, lots of beautiful scenery and calmness, and lots of learning and exploring. Lastly, I'll let you know that on Saturday, Pilates on tour from Balanced Body, I'll be presenting for them. There's still space available. You just go to Balanced Body, Pilates on tour, and that's virtual, and that's going to happen. Also, there is the Pilates Summit, and that is June 6th and 7th. That's through Lolita's folks. So keep your eyes out for that. And I think that's all I have for you. Oh, I was going to tell you the spine deformity course that I talked about with Lisa Stoltz and with Hagit. That will be coming live online probably in the next 3 or 4 months. So they're hoping to get the asynchronous portion of it up online by June or July. And we'll have some dates for the live portion of it happening either in the fall or the winter of next year. That's all I got for you today. Be safe, be sane, be kind. Please always take the high road and realize that we are the example, and take good care of yourselves. Things are looking up. Our prayers go out to our friends in countries that are still really suffering with shutdown and severe COVID virus. So keep them in your prayers and your thoughts and your meditations, and we'll see you next Thursday.